Hi, this is Dr. Upasana Dahiya. I am PG3 resident from Department of Radio Diagnosis, KIMS, Bhubaneswar. My topic for CT Buzz is MRI and CT Spectrum of pineal gland tumors, a case series. So tumors of pineal region are rare, accounting for less than 1% of all intracranial neoplasm. Their rarity, coupled with the complex anatomy and diversity of cell types in the pineal region, results in broad histopathological spectrum. Clinically, patient may be asymptomatic in case of small lesions such as cysts, or they may present with symptoms due to mass effect, including Perinaud syndrome, obstructive hydrocephalus, headache, and raised intracranial pressure. Classification of pineal region tumors include cyst, germ cell tumors, pineal parenchymal tumor. Cyst benign lesion include pineal cyst, most common benign pineal mass, and inclusion cysts such as dermoid and epidermoid. Germ cell tumors, germinoma, embryonal carcinoma, choriocarcinoma, yolk sac tumor, teratoma, and 50% of the primary pineal tumors are germinoma. Pineal parenchymal tumors include pineocytoma, pineal parenchymal tumors with intermediate differentiation, and papillary tumor of pineal region, and pineoblastoma. These account for 30% cases. Others are gliomas, metastatic or secondary tumors, meningeal tumors, vascular lesions, which are quite uncommon and rare. The purpose of this case series is to illustrate the CT and MRI spectrum of pineal region pathologies and to highlight the key differentiating imaging features that are instrumental in achieving accurate diagnosis and appropriate clinical management. The patients were evaluated using GE 128 slice CT scanner and GE 1.5 Tesla MRI machine. This is a first case of 72-year-old male who underwent NCCT head for recurrent headache, where we can see that there is an incidental finding where there is a well-defined cystic hyperdense lesion showing peripheral calcification. Based on the imaging, it was reported as pineocytoma. All these case images described in the case series are from the Department of Radiodiagnosis, KIMS, Bhubaneswar. Another case is a 19-year-old male who came with the complaint of occipital headache since 2 to 3 months and vomiting since 1 month, who underwent NCCT brain for further evaluation, where we can see that in the pineal gland region, we can see there is a heterogeneous solid cystic lesion with intralesional hemorrhage and internal calcification. There is mild lesional edema and mass effect in the form of obstructive hydrocephalus. Imaging features were suggestive of pineal germinoma, and differential diagnosis of tectal plate glioma was given. The same patient underwent CE-MRI, and on T2 weighted imaging, we can see there is heterogeneously hyperintense solid cystic lesion. And on T1 imaging, it shows heterogeneously hypointense lesion with focal areas of T1 shortening suggestive of hemorrhage. On diffusion weighted image, we can see that the solid component shows diffusion restriction suggestive of high cellularity. On SWI imaging, we can see there is multiple blooming foci indicating intralesional hemorrhage, and there is peripheral hemocytrin deposition. And on phage imaging, it was seen that there was specks of internal calcification also. On post-contrast T1 and coronal image, we can see that this lesion is heterogeneously enhancing and has supracellular component and is having mass effect causing upstream obstructive hydrocephalus. Overall features were suggestive of pineal region germinoma, which was later confirmed by histopathology. Third case is a 23-year-old male with complaint of headache and recurrent vomiting. Patient underwent CE-MRI brain for further evaluation. On T1 weighted image, we can see a well-defined lesion in the pineal gland region, which is iso-intense on T1, and while on T2 it is heterogeneously hyperintense, causing dilatation of the third ventricle. And on DWI imaging, it shows the solid component is showing diffusion restriction, suggesting of increased cellularity. On post-contrast imaging, we can see that it is heterogeneously enhancing, and there is a lobulated extension in the cerebral aqueduct, and it is causing upstream mild hydrocephalus. On phage imaging, there is a speck of peripheral speck of calcification, and which is hyperintense foci, and on MRS, it indicated decreased NAA peak with elevated choline and creatinine peak, suggestive of neoplastic etiology. And based on morphologic and enhancement characteristics, pineoblastoma was given as the diagnosis, and which was further confirmed by histopath. Case 4 is a 27-year-old female with chronic headache, blurring of vision and vomiting. NCCT brain revealed an ill-defined heterogeneous solid cystic hyperdense lesion in the pineal region causing hydrocephalus. The impression of pineal gland neoplastic etiology was done, and she was further advised for CMRI. So the NCCT was done in outside, and patient came for CMRI in the department. So on T2 weighted imaging, it shows a solid cystic hyperintense lesion in the pineal and posterior third ventricle region. And on SAG image, we can see that it is solid cystic and has heterogeneous internal signal characteristic. And on diffusion weighted imaging, it shows that there is foci of diffusion restriction in solid component. However, this is post EVD placement case, and there is reflecting partial resolution of hydrocephalus. So on SWAN imaging, we can see that there is multiple foci of blooming within the lesion, suggestive of hemorrhage or calcification. And on post contrast, we can see that there is heterogeneous enhancement, and there is a conglomerate ring type enhancing solid component, and located in the posterior inferior aspect of the right side. So the lesion was reported as pineal gland neoplastic etiology with differential diagnosis of pineoblastoma and pineal parenchymal tumor of intermediate differentiation. However, on histopath evaluation, it was confirmed to be a low-grade astrocytoma. Now, case 5 is a 44-year-old male who came with the headache and features of raised intracranial pressure. He underwent CCT brain for further evaluation, where we can see a solid mildly enhancing lesion in the pineal region. And on post contrast, it was vividly enhancing, and had a patient causing mass effect in the form of obstructive hydrocephalus, and these features were suggestive of pineal region meningioma. So pineal region tumors are rare, heterogeneous, and often requires histopathological confirmation due to overlapping imaging features. Our series consists of 5 cases: pineal meningioma, pineoblastoma, germinoma, low-grade astrocytoma, and pineocytoma, and demonstrate their varied radiological appearances. Thus, imaging clues such as calcification pattern, enhancement, lesion architecture, and patient age can suggest a likely diagnosis, but tissue confirmation remains the essential. The radiology roles lies in narrowing the differential, detecting complications such as hydrocephalus, and guiding surgical and adjuvant therapy and decisions. These are my references. Thank you.